our longest, or my longest module of the semester. We're gonna breeze quickly through a little bit of pancreatic hormones. We're gonna spend a lot of time on diabetic drugs, and if you've been in the medical field for about 10 years, you know that or more, you know that diabetic agents have really boomed since about 2011, 2012, sometime around there. We've added several new classes, and we'll get into them, but they have amazing data that we'll talk about, which is really making a lot of the other ones, a lot of other agents obsolete. And then we're going to finish up with with thyroid dysfunction. Quickly go through hypo and hyperthyroidism because there's just a few things used to treat both of them, and kind of knowing what the differences are, and what to monitor. There we go. So, for a review, you want to review the endocrine system and hormone regulation, looking at drugs that affect the endocrine system. You're gonna We've already talked about bisphosphonates for osteoporosis. Then you have hypothalamic and pituitary hormones, exocrine pancreatic enzymes, which are going to be just exogenous pancreatic enzymes that you take, by mouth, to replace what you're lacking, diabetic agents, and then anti-thyroid and thyroid agents. So pancreatic enzymes, a lot of times are used in cystic fibrosis or in pancreatitis, and then you can also use them in bariatric procedures. Some things to keep in mind with these: you cannot crush or chew them. You can sprinkle them on food if they do come in a powder form. You want to take them immediately before or with a meal. You also want to keep in mind that, let's see, yeah, so we're gonna keep in mind that these pancreatic enzymes are not interchangeable. They all have slightly different amounts of different enzymes in them. There aren't generics available. At our facility, we've had to use them a few times, and a lot of times we'll get recommended to have so many thousand units of this enzyme 1, 2, and 3, and then there's other names for them, but there's 3 in there, and then you have to kind of find the one that is the closest and making that dose. They're not interchangeable as far as generic equivalency, bioavailability, strength, anything like that. So it can become very difficult, especially if a patient has been stable on one for a long time, and then you're having to find something because there's a back order, or now insurance changes, that kind of thing. So highly recommend doing the prior authorizations for your patients if they have done well on a certain pancreatic enzyme, because it's not that easy to change. Pharmacokinetics, they have no absorption because they work there. They're excreted in the feces. One thing, pancrelipase is made from pork, so you want to watch for that for people who have religious reasons or allergy reasons. They can't have pork or beef or certain vegetable sources for the pancreatin. And then antacids will decrease the effectiveness and decreases absorption of oral iron. For most patients, given at an adequate dose, they're not going to have any adverse drug reactions because we're replacing what they don't have. Under rational drug selection, again, watch products because they're not bioequivalent. There's a lot of formulations that used to be out there, but they were taken off the market due to lack of FDA approval. So there's a few out there now. Honestly, it's best to just kind of, if you're going to have to treat somebody with it, pull it up on UpToDate, Lexicomp, Micromedics, and see what options there are on the market, because they'll tell you which ones have been taken off the market. So monitoring. First, you want to warn somebody for pancreatitis. You're gonna is contraindicated during acute exacerbations of the illness. Obviously, hypersensitivities, if they're allergic to something that's a part of it. You're going to monitor these labs, and then and then we're gonna. It's really about it. We're gonna um, look at how much lipase, protease, and amylase is in um, in each drug, and then you're going to use that to figure out how many tablets, or I'm sorry, capsules you're going to give somebody. So it may be 2 tablets by mouth with each meal, or 2 at breakfast, 2 at lunch, and 1 at dinner, depending on how much replacement they need. The drugs are prescribed in units of lipase, so that's going to be the first number that you see um, on the when you're looking it up on Lexicon for Micromedics. And again, um, FDA removing some older formulations has made getting the exact right dose very, very complex. And this is probably something you may continue therapy. Um, if someone's admitted to your facility, but this is probably going to be followed by an endocrinologist, or someone who specializes in it. So, on to another pancreatic hormone, insulin. So, this is where we're going to jump into the diabetic agents. So, insulin has been around for a while. It is one of our older diabetic agents. For a long time, insulin and sulfonylureas were all we had, and we would give insulin a couple times a day with a sulfonylurea, and then titrate the insulin dose to match how many carbs they're taking in, or a sliding scale to treat whatever their current blood sugar is before they eat their next, or after they've eaten, 2 hours postprandial as a correction. But that has changed. Now, insulin has still stayed a mainstay of diabetic treatment, and we'll see towards the end of these slides where it fits in, because I've got some pictures of the newest algorithms, and I would highly recommend to all of you, pull up the most recent algorithms that I should have. They should be on Canvas, and you can go to the American Diabetic Association, or and get a nice PDF, and they have very good algorithms that you can follow. But I would bookmark that page, or print it out, have a little copy with you, because one, there's a lot of diabetes out there, and two, it is getting more complicated treating patients, and we're having a shift in treatment of patients from just getting blood sugar down to preventing cardiovascular and renal events. So it's about preventing cardiovascular death, heart attacks, strokes, preventing renal failure, preventing amputations, preventing vision loss. That is actually a requirement for anti-diabetic agents that are going to hit the market. And we'll talk about that in a little bit when we talk about some of the newer agents that are quickly replacing the older diabetic agents. But insulin itself. Insulin is a natural hormone that the pancreas produces. It is going to, depending on which one you give, you're either going to give it as a basal dose, which basal means once or twice a day, usually once, and that's going to cover the kind of the fasting blood sugars throughout the day. Or you're going to give it. You can give it with meals, where it's like a Humalog or a Novolog, where you're treating the carbs that the number of carbs a patient is eating. And there's simple math equations you can go through to kind of figure out, once a patient's on it, how much you can bring the blood sugar down with 1 unit of insulin, or how much 1 unit of insulin kind of covers this many grams of carbs. And so if you're doing a lot of that specific insulin dosing, then I would look those up, and definitely have those ready. But it acts in the body. It promotes the use of glucose in the bloodstream to enter cells, to provide energy, to cross the blood-brain barrier, and because glucose is the only source of energy of energy for the brain, and it also promotes protein synthesis in the muscle cells, and it acts in the liver to increase storage of glucose as glycogen. So those are some all benefits of, um, of insulin, and it reduces the circulation of free fatty acids and promotes storage of triglycerides in adipose tissue. That right there is something we have seen where um, some patients who've been uncontrolled diabetics for a long time with high A1Cs will actually have elevated triglycerides because of that increase in glucose. So a lot of times you may put them on something to treat the triglycerides, and then they can probably come off of that medication once you're once their blood sugars have come down, their A1C is decreased. So insulin comes in a few options. You have rapid acting, and these are your three options here. Onset's about 5 minutes, peak is 30 minutes to an hour, and the duration is about 4 to 5 hours. Now, one thing with rapid acting, I like to tell patients when they're going to take it, is it is very fast acting. So the great thing about these is a patient can give them right before they eat, which may not have been an issue, when they're eating at home. But if you're out at a restaurant and you were taking another insulin that took longer than 5 minutes to start working, you probably had to give yourself your shot and then drive to the restaurant, order, and get your food and hope you got it in time. But with these insulins, they come in pens. They can dial up how many units they need, order their food when it's coming to their table, go to the restroom, give themselves their insulin, and then come back and eat. And it's great. And the saying I tell patients to remember with this is for rapid acting, so Humalog, Novolog, or Apidra, when your food is hot, give your shot. You don't want to do it before then because something may keep you from eating. And if you're delayed 30 minutes to an hour because of your kids or your dogs or the restaurant's busy or whatever, there's a good chance you're going to become hypoglycemic. So when your food is hot, give your shot. These are the ones you're going to use for postprandial correction, like a sliding scale, which is, if your blood sugar is from 200 to 250, give yourself 2 units. If it's 251 to 300, give 4 units and going up. And you're going to use this for for patients who are giving a certain number of units per carbs. So if they're like a type 1 diabetic and they know they're eating 30 grams of carbs and they know they need to give themselves 10 units of insulin. That's the kind you're going to give is that rapid acting. Short acting is somewhat of a misnomer, but only because it's shorter acting than our other options. It was the shortest acting until rapid acting came to the market. So that is your regular insulin. So Humulin R, Novolin R is just regular insulin. That's what it's called. So you take it about 30 to 45 minutes before a meal, and then it peaks in 3 to 4 hours and has a duration of 4 to 10 hours. So that one is not commonly given by itself. It's usually given with the next one that we've talked about, or the intermediate acting. So normal pressure hydrocephalus mixed with protamine, blah, blah, blah. Tell you that's NPH. So Humulin N, Novolin N, that is an insulin that it's cloudy. You have to roll it in your hands before you give it, especially if it's because it's going to separate out. But you roll it in your hands. You never shake insulin. Insulin is a protein. If we shake it too hard, we're going to break it down. If we heat it up too much, it's going to break it down. We've got to keep these at room temperature for up to 28 days in the fridge before it's opened. That keeps it good for a much longer time. Once the insulin's open, they can keep it in the fridge if they'd like to, but they don't have to, and it's going to go bad, most of them, within 28 days of opening that vial. So, they may only take a few units a day, but, and that vial lasts them 150 days, but it is not, because it's not sterile once you've put that first needle into it, it's only good for 28 days. So, your NPH. NPH has you can see on the bottom line right here, it has a duration of 12 to 24 hours. So what this may have a benefit of is if your patient cannot afford one of these long-acting insulins, which have a duration of 24 hours or more, NPH can be an option as their basal insulin. They can take it twice a day, and it can act as um, that that maintenance insulin that they're on. And then they can use the rapid or the other ones for short acting for meal times or to as corrections if they need to. Now, you can also use some people will also use there's a mixture. There's mixtures of insulin. So the NPH and the R can come as like a Humulin 70/30. And so you're getting 70% NPH and 30% R, which can help some patients because you still give it twice a day, but the R helps cover some meal times, and then the NPH can steady over about 12 hours. So you can use that one. That is a really good insulin for patients who can't afford the long-acting insulins. Now, and I don't think it will ever stop, but the RNs and 70/30s for Humulin are available at Walmart for $25 a vial, which is incredibly cheap compared to the other insulins, which is a shame because most people don't realize when insulin was discovered and started to be used as a treatment, the man who discovered it did not patent insulin because he thought it should be available to everybody very cheap. Insulin itself is very cheap. It's the different formulations and the technology that the drug companies have patented and are making obscene amounts of money off of people who really don't have any other option for treatment. So it's a shame that they do cost so much. Now, another one that you've probably seen a lot of, your long-acting insulins, your Lantus, Levemir, and Tresiba. Now, but unless it's on an insurance formulary, I don't see quite as much Levemir as I used to. Levemir has a slightly shorter duration, and some patients have to have a twice-a-day dosing on Levemir. Lantus has a solid 24 to 28-hour duration, so you can give it once a day, and it's fairly steady throughout the day without a true peak to it. It's very pretty flat once you reach steady state. And then you have the Tresiba, which is fairly new, which is just another option for a once a day insulin. I've seen some people who don't quite get control on one; they'll switch to another just to see if it's easier for them. I don't think one is better than the other ones. I just think it might be, that little bit of change in duration or the onset or something like that may help them get control. But I've seen really good results with all three. And with any of the insulins, it's about how much ownership the patient will take in their treatment, because they're gonna have to prick their fingers and check their blood sugars to get it. They're going to have to inject themselves, and I tell you, I've told this to patients, educating them. I've showed them when I've been teaching them. I would much rather give myself a shot of insulin than I would prick my finger for the testing. For some reason, there's this phobia with the insulin needles that they just won't do it, but they'll check their blood sugars, and it's so much more painful to check your blood sugars than to give yourself an insulin shot in the stomach. Especially if you rotate injection sites around the stomach. It's almost, you really don't feel it because the needles are so small. They're nothing like what you give a normal injection or a vaccine with. They're very, very small, and the smaller the person, the smaller the needle is. So whenever you are writing a prescription for an insulin, make sure you write them a prescription for the needles, what gauge, what length, how many units. They come 30, 50, and 100 units, so you want to make sure that it's not too big. If they're getting 5 units a day, you can't measure that on a 100-unit syringe. So you want to keep it to something that's that's close. And then you want to make sure if it's something with a pin needle that you're also writing or pins, you give them a pin needle also. And if you want to write a prescription for their glucometer, their test strips, their lancets, and the lancet device, go for it. It might be covered on insurance. If not, Walmart is the place to go. They have another generic. It's not really generic. It's It's one of the manufacturers, just like they do with the insulin, who lets them sell it at a discount because of their contract. They also have the same thing for a glucometer and test strips and supplies. So you can get out with everything you need for about $50, as opposed to several hundred with some of the name brand companies. And it's the same machine. It's just it's called Rely On instead of One Touch or Contour or one of those companies. Here's a chart that I really like comparing the insulins. Rapid acting, you can see here on this chart, it does have the inhaled insulin that was not on there earlier. I believe that is still on the market. It's inhaled insulin's tried several times to get to the market, but it's always had issues with stability and tolerability. I think it's still on there. I've never seen anybody use it, but that's also because, I'm not sure if that may be from what I'm seeing. It may actually be in use. I just haven't actually seen it in use yet. You're also going to see down here insulin glargine U300 and U200. That is the number of units in a milliliter of insulin. It's normally 100. But if you have a patient who needs just such a high amount of units, you can go to a higher unit insulin. There are a few out there, U300 glargine being the one that I've seen the most of, but you have to be very, very careful with this because that is 3 times the concentration of a normal insulin. If the wrong one is dispensed or if the wrong one is written for, you have a chance of killing a patient because their blood sugar is going to go so low. I have seen that before. I had a patient at our psych hospital who actually tried to commit suicide with insulin before. When the EMS got there, they couldn't measure a blood sugar. She lived, but she honestly pretty much starved the short-term memory part of her brain, so she did not have a short-term memory. I'll tell you all about her childhood, everything up to last week, and then she couldn't tell you what she had for breakfast. So you have to be very, very careful with those U300 and U200 insulins. I can say in the 13 years I've been in pharmacy, I've seen a handful of them used. It's not that common, but it is something you have if you need it. Here, I like this chart too. Insulins to use and what blood glucose you're targeting. So if you're targeting their pre-breakfast fasting, these are the ones you need to target: bedtime or pre-dinner MPH and glargine. If it's pre-lunch, post-breakfast, here's what to target, and on down the list. Because sometimes it doesn't. Sometimes it doesn't make sense. Which ones you're targeting, so it tells you which ones to adjust, which insulins to adjust for which ones you're targeting. So kinetics is determined, absorption determined by the type of insulin. I would not change an insulin based on what type of absorption it has. You're going to go with how long you want it to use. You want them to use it and what you're using it for. Watch for standardized U100 needles. That's what everything comes in. It's to measure U100. So if your patient has to go above that 100 units per milliliter, they're going to need extra education with how to draw up their doses. ADRs, hypoglycemia, is not a shock. If you give too much, or the patient continues their medication when they're not eating or some kind of change, then they'll become hypoglycemic. Watch alcohol use. This is a common thing that we've seen in college towns, especially for type 1 diabetics who are either who alcohol use can increase hypoglycemia, or they don't take into account the number of carbs that are in alcohol. Especially sugary drinks and beer, they have a lot of carbs in them. So you'll have a patient who develops diabetic ketoacidosis, which can be fatal, and who ends up going to the emergency room because they're not adjusting their insulin appropriately. Seen that in a lot of college towns where they're around that legal drinking age. Beta blockers masking hypoglycemia symptoms. This is very important. They will mask the symptoms of hypoglycemia, except sweating. That's the only one that's not going to mask. So if you have to have a patient who needs a beta blocker for some kind of cardiovascular reason. They don't have any, there's nothing else they can use, or they have an indication like post MI, something like that. You have to let them know that it may mask their symptoms of hypoglycemia. So the only one they're going to have is sweating. So if they are sweating without a clear reason why, then they need to check their blood sugar, because everything else will be masked. Now, pregnant women can use insulin. It does not cross the placenta, so that is an option for treating women who are pregnant. There are other options also, but it's definitely one that can be used without risk of the child. They want to be more careful checking, because obviously if the mother goes low, so does you're not going to have the glucose crossing the placenta also. So they probably want to check more times per day. Here's how you can adjust for hypothyroidism, hyperthyroidism. Once you get them normalized, then you can go back to the way they were, giving themselves insulin. So, hemoglobin A1C. You are going to want to test a patient at least twice a year who are at goal, and you can test quarterly for patients who are not at goal. The reason it's quarterly is an A1C tells you your average, how your blood sugar has been in the last 3 months. Now, it's not exactly an average. A1C is determined by about 50% of your A1C, which comes as a percentage, goal being below 7% if you're a diabetic. 50% of that A1C percentage comes from your last month. The month before that is about 30%, and then the furthest back month, so like days 61 through 90 in the past, is about 15 to 20%. So you'll see you can only do it quarterly, because you're not going to see that big of a change if you come back and have them do the A1C, or you're not going to see enough change if they come back in a month, because there's still benefit to be had. You might be over treating the patient. If you check them in a month, their A1Cs only come down to 9%. We increased their dose, but it would have come down to 8 if we had let it go for 4 months. So you can actually do point of care testing for A1C. So you can just prick a finger, do a point of care test. You don't actually have to get a venous blood draw to check it. Now, if you're getting it for renal function or other things, go ahead and add an A1C to it. But it is nice having point of care testing, because you can get it quickly and much less painfully. So goal of A1C is less than 7% for most non-pregnant adults. You can individualize goals for older adults with long-time diagnoses, because number one, they're going to be harder to treat, and number two, they may have symptoms of hypoglycemia at a higher blood sugar than other patients. So you may say 8%, 8.5% is going to be our goal for my 80-year-old diabetic patient, because I really don't want them sitting with a blood sugar of 70 all the time. There are charts that kind of equate an A1C to a percentage. I want to say that A1C of 6 equates to about 126, a blood sugar about 126, and then each percent going up is about 25, an increase of 25. But there are nice charts that I suggest printing out. You can give them to your patients. They kind of know what they're how they're doing, what it means, because the percentage to them probably doesn't mean a whole lot, but they know what their blood sugar is because they check it. You want to have other things for patient education. You want to have an emergency plan for glucose readings if they're sick, because they're going to be off. I recommend getting the plan from the American Diabetic Association. You always want to push lifestyle management, diet, and exercise, because that is the gold standard, or the number one treatment for diabetes, along with just about everything else. If you can control it with lifestyle management, diet, and exercise, control it with that. But it's not always an option. So, Oral diabetic agents. Well, before we move on for insulins, if you have more questions or you want more resources, please email me or send me Canvas um, messages. I think there's a lot of stuff in Canvas already, but I don't think you can have too much because we're just getting more and more options. So please feel free to reach out with questions, even if it's not during this class. My email address doesn't change, so feel free to reach out to me. Oral diabetic agents. So there are quite a few oral diabetic agents that we are going to use for type 2 diabetes. Insulin is the only treatment for type 1 diabetes. Insulin can be used for type 2 diabetes, but also the other diabetic agents can be used. So you're going to have a few options for what to do. So some will actually increase production of endogenous insulin, and those are sulfonylureas. So glipizide, glimepiride, and glyburide. You're going to see those used. They have kind of a ceiling effect. You can only get so much insulin out of the pancreas, but we'll talk about that in a minute. You can increase in sensitivity to insulin, like TZDs or Actos and Avandia, or biguanides, which is metformin. And then you can also use some that impaired response of beta cells, which meglitinides. Don't use those a whole lot anymore, but they increase the secretion of insulin through a different route. Anything that increases the insulin production or secretion can cause hypoglycemia by itself. Anything that just increases sensitivity to insulin, like TZDs and metformin, don't cause hypoglycemia by themselves. Given with an insulin, they will, because that also increases your insulin in the body. So some other options or some other routes that they work, helping with excessive production of glucose in the liver, metformin. You'll see metformin a lot on these slides because metformin is the gold standard for treatment of type 2 diabetes. There's nothing better than metformin. You have impaired GLP-1 activity, so we can give a DPP-4 inhibitor or we can give a GLP-1 agonist. We'll talk more about those in a few minutes. Those are the two of the ones that have come about recently. And some of those can stop weight gain or help with weight gain. So sulfonylureas. These three listed here are the three that are left on the market. You've seen a drastic decrease in the use of these with the newer agents that have come to market because they all stimulate insulin release from the beta cells. Hypoglycemia is a major side effect, especially in the elderly. Which is why we try not to use any of these in the elderly patients. We definitely don't use glyburide, and because it's not cleared as easily. But hypoglycemia is seen a lot in these patients. Basically, you're just using it to wring out the pancreas a little bit more and get some more insulin out of it. You cannot control how much insulin is gotten out of it. If you don't eat, you're going to be hypoglycemic. Contraindications, sulfa allergies or thiazide diuretics allergies. You avoid them in pregnant women. Older adults are more sensitive to hypoglycemia events. That's because they're renally cleared, and older people don't have as good renal function, no matter what their serum creatinine says. And you can have an unlabeled use in the pediatrics from ages 10 to 18. You can see your ADRs, the biggest one really being hypoglycemia. And drug interactions are going to be things that increase and decrease hypoglycemic effect. So usually you're going to see, in addition to a hypoglycemic agent, insulin, metformin, any of those other ones. Clinical use. It says use second generation agents most of the time. The first generations aren't on the market. So you have to use glipizide, glyburide, or glimepiride. You can individualize the dose. We personally don't use anything but glipizide. It's a little bit steadier, and it comes in an ER, extended release version that you can give once a day, and it just leads to better results, and it's still fairly cheap. So I would try sticking to that. But my opinion is that I think sulfonylureas are gonna. Honestly, I think they're going to be used. They're going to be used so little, 10 to 15 years from now, that they may just actually be pulled from the market because of the drugs we have coming. Because in sulfonylureas, They may help with blood sugar, but they don't do anything for those macrovascular and microvascular events of diabetes. They don't do anything to prevent heart attacks and strokes and kidney failure and renal and blindness and things like that. So, I think we're seeing them used less and less and less now, especially as our older prescribing population retires, because they're still they remember an age when we had insulin and sulfonylureas, and that was it. That was all we had. So we're slowly getting better, more tolerable options, better, more efficacious options that have been great. So monitoring hemoglobin A1C every 3 months until it's at the normal level, then every 6 months. Patient education is important. So you definitely want to educate your patients on what to expect when you're starting one of these medications. Metformin. Metformin you're going to see on any guideline as the top choice for treating diabetes. So it decreases the glucose production in the liver. It decreases glucose absorption in the GI tract. It improves insulin sensitivity, and it does not stimulate insulin release from the beta cells. And it inhibits platelet aggregation and reduces blood viscosity. So very, 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 very minimal risk of hypoglycemia. Really non-existent in my opinion. I don't worry about giving someone too much metformin, because there is kind of a ceiling effect of how much you're going to. You can only decrease glucose production so much. You can lose weight on metformin. It's not going to be huge. They're better off trying to manage their diabetes with their diet also, and then lose weight through a natural weight loss, not just by taking metformin and continuing to eat what they were eating. But you could expect a couple kilogram weight loss once they start taking it. Absorption. Food. It says food decreases and delays absorption. I would definitely give this with food. It's not to improve the absorption. It's because that it causes horrible. It can cause horrible flatulence and diarrhea if it's given too much too fast. So start at a very low dose, 250 milligrams or 500 milligrams daily, and increase up every couple weeks. Every 2 weeks, increasing by 500 milligrams to get to a goal dose of 2 grams a day. If they're having symptoms and they can't tolerate the immediate release, go to the extended release metformin. It's still pretty inexpensive. The 500 milligrams and I think 1,000 milligrams are less than $10, even for the extended release. It's much more tolerable in the stomach. But you have to start low and go slow when it comes to metformin. Start a low dose and increase and titrate it very slowly. Because even if their blood sugar is not at goal, they're still getting the benefits that has been seen with metformin of decreasing all those cardiovascular events and all our macrovascular and microvascular events, regardless of blood sugar and A1C control. So, precautions: renal and hepatic disease. So the renal disease, metformin used to have a hard cap on serum creatinine of 1.4 or 1.5, depending on if you're a female or a male. That is no longer the case. It's just because it is cleared, renally. So it was to that renal. It was to decrease the risk of metabolic acidosis, which we're gonna talk about, or lactic acidosis. We're gonna talk about. The next slide says it's a risk. I'm gonna tell you why it's not really the case. You're going to want to withhold drug 48 hours before and after any procedures for drug interactions. You want to watch patients with B12 deficiency. This is one that I remember when this came out, that metformin, long-term use for metformin caused B12 deficiency. Well, B12 deficiency a lot of times presents as peripheral neuropathy. Well, what do patients develop after years and years and decades of uncontrolled diabetes? Peripheral neuropathy. So we were having the internal medicine clinic I was in, they were having a lot of patients having dose adjustments based on peripheral neuropathy, and then getting put on gabapentin and all these other drugs to try to treat their peripheral neuropathy, when we may have been able to prevent all those medication changes by getting a B12 level. Um, and then just supplementing either by injectable B12 or oral B12, just giving enough where enough is absorbed. So if you have a patient who's been on metformin long term and they're developing it, let's get a B12 level before we just add on more medications and increase their pill burden and the cost of the disease, because diabetes is an expensive disease. All the equipment, all the medication, all the lab work, missed days of work. It's a very expensive disease. So let's do what we can before we just add on more. So that lactic acidosis, or metformin-associated lactic acidosis, you're going to commonly see. It is very, 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 very rare. I think that you'll never get a link that says it doesn't happen, but the risk of lactic acidosis is given to metformin because of its predecessor fenformin. A generation previous biguanide, which hasn't been used for a long time. It's very, very rare, and I've never actually seen a patient who had metformin-induced lactic acidosis. So you just want to watch a patient's serum creatinine or GFR, and then if they're starting to reach stage 4 or end-stage renal disease, you want to stop the metformin, because it's renally dosed once they have kidney issues. So, rational drug selection, start with 500 milligrams twice a day. I would recommend once a day. Twice a day is not wrong. You're going to get them to taking it twice a day if it's the immediate release, but there's a lot of patients who, when they have GI side effects from metformin, they're not taking it again. You can't convince them no matter what. So it's much better to go slow because of all the benefits we're seeing, and I can't begin to cover. We could talk a whole semester on diabetes. I can't begin to cover everything these drugs do, especially outside of bringing blood sugar down. So there's too much benefit of metformin to waste it by trying to speed it up and get them to 2 grams a day, as quickly as possible. This right here says patients, if they've not responded within 4 weeks of high dosing, consider adding a sulfonylurea or other medication. I would switch that and say other medication, and if you have to and they just can't afford anything else, then add a sulfonylurea. 20 years ago that was a common combination. Heck, 10 years ago it was a common combination. But as we've gotten more and more of the other medications on the market, you're not seeing those sulfonylureas used as much because of the benefits of the other ones. So, alpha-glucosidase inhibitors. A few of these next classes we're going to go over just for completeness, but I don't see these used as often. They inhibit acarbose and migdal. Acarbose would probably be the one you see actually used if you did. These are not monotherapy drugs, and you have to treat hypoglycemia with milk because of the way the medication works. If you inhibit the absorption of carbohydrates, you lower the blood glucose. Well, if I can't get carbohydrates for hypoglycemia, I can't treat it. So you give them lactose because it's not sucrose, and therefore will still work. You can see lots of gas. Most patients do not tolerate this very well. So bad that it's not used very often at all. You have to take it several times a day. Should not be taken in pregnancy. Do not use it in pediatric populations. It's just not. It's got some drug interactions. It's just got a lot going against it. 3 times a day, really bad gas, diarrhea. They're not going to want to take. In populations you can't take it in with GI disturbances. There's other things. Let's not use the alpha-glucosidase inhibitors. TZDs, you see these used a little bit right now. Pioglitazone or Actos a lot more than rosiglitazone. They improve target cell response to insulin. So they're kind of like metformin light, if you want to think about it. They don't cause insulin secretion. They're in the periphery, causing the body to use insulin better. So they don't cause hypoglycemia, but they do have um, other negatives that they can cause. So you can see here, you go through the absorption, metabolism, very little, in drug interactions, but they do happen. Um, you can have contraindicated in heavy liver or chronic liver disease. They can cause fluid retention, which can exacerbate heart failure. So that's one of their the restrictions on Avandia. That it's seen with Avandia, not Actos, but Actos does have there's a chance that it increases. It's increases prostate cancer. Yeah. Um, no, bladder cancer. So the FDA put really big restrictions on Avandia, and they're slowly loosening those because maybe it was a little bit overblown. Um, but it's got positives and negatives. It's once a day. It doesn't cause hypoglycemia by itself, but there are these risks that if you have a family history of bladder cancer, or if you have heart failure or cardiovascular um, comorbidities, you probably don't want to use these because of that fluid retention. So I have seen a little bit of an increase back in use of these in the past few years, but I think it's it depends on the patient. Let's see, drug interactions, rational drug use. You can see here where they can be used. It's kind of it depends on the patient. Meglitinides, I haven't seen these used in a couple years. They increase insulin release from beta cells. Um, time in plasma is short, less than 2 hours, so they only work on postprandial ones. So their name brand, they work on postprandial. Most people would rather go with insulin at that point because its insulin is a lot more stable. I know what 4 units does of insulin. The other ones they can be kind of you may have a little bit more varied results. You can have hypoglycemia in vulnerable populations. There are some drug interactions with meglitinide and some of your antifungals, and you still have to give it before each meal. Then you double every 2 weeks, and it's a little more complicated than what a lot of people are willing to do for the minimal A1C benefit that you're going to get. You're going to see a lot of medications, if you get some good diagrams, is based on what kind of A1C decrease can you expect. Now, obviously, you get a larger A1C decrease if your patient starts out at 15 than if they're at 8. But these medications are a decrease of like 0.5%, whereas metformin, insulins, glipizide, our sulfonylureas, and our newer medications are 1 to 2%. So it's really, is it worth the benefit that you're getting? I think most people would say no. Now we're going to jump to the newer classes of medications. Your gliptins, your DPP4 inhibitors, and they're gliptins because you've got sitagliptin, saxagliptin, and there's more on the market now. What they do is they inhibit DPP4. So DPP4 is an enzyme that breaks down GLP-1, which is an enzyme that is released in response to eating. So it gives you it signals that you're full and that your body should secrete insulin and suppress glucagon and kind of do what it needs to do because you've eaten enough. So you have, because GLP-1 is good, we can give these gliptins to inhibit DPP4. Now, DPP4 inhibitors are great because they're oral. They're once a day and they're very, very well tolerated. The only hiccup they have is that they kind of lose their efficacy after about 5 to 10 years of a patient being a diabetic, because diabetics have their GLP-1 will decrease the longer they have uncontrolled diabetes. So, you can only, even if you're inhibiting that enzyme, if your endogenous GLP-1 is very low, you're not really going to get a benefit of stopping its metabolism, if you get what I'm saying. Um, so the next option would be to give a GLP-1 agonist, which acts as GLP-1. You don't give these two together. Your gliptins and your GLP-1 agonists that we're going to talk about in a few minutes, you don't give them together. Because there's no benefit. Increased risk of side effects, but there's no benefit because you're kind of maxing out the system by doing just one. So don't give both of them together. So great thing about DPP-4 inhibitors is it promotes pre and postprandial glucose levels, so it helps your fasting and your postprandial. Promotes mild weight loss. Contraindications are renal dysfunction. Possibly pregnancy, and it's not approved in women and children. So with DPP-4 inhibitors, I've seen that the ADRs are GI, so upset stomach for the first couple days taking it, nothing like the other metformin or the other medications, and headache. Slight increased risk of pancreatitis with them, but not even to the point where you would, you probably just wouldn't give it to a patient who has pancreatitis. They're very, very well tolerated. They're dosed once a day. Is it natagliptin, I believe, can be given, is not renally dosed, so you have an option even for patients who have renal dysfunction. And they're very well tolerated and very efficacious. And DPP-4 inhibitors have been shown, most of them have been shown to, if nothing else, they are equal to or better than placebo at preventing cardiovascular outcomes. Now, this is the first time we're going to talk about those cardiovascular outcomes, which you're going to see in presentations for diabetic medications, abbreviated as CVOT. And so all diabetic medications from now on have to have data proving that they are at least as good or better than placebo at preventing those outcomes. It's great that blood sugar decreases, but they're now demanding evidence that it decreases heart attacks and strokes and hospitalization and death by cardiovascular event and those types of outcomes. So you're going to see those because metformin has an outrageous amount of evidence for that. The other antidiabetics up until DPP-4 inhibitors did not. DPP-4 inhibitors are kind of considered neutral in that they're shown to not be inferior to placebo, where some of the other medications are. But the trials just either weren't quite designed well enough, or there weren't enough patients to show that there was a benefit in them. But they're still really good medications. You can use them as monotherapy if you have a patient, especially one who is pretty well controlled diet and exercise, needs another 1 or 2% drop in their A1C and just won't tolerate metformin. It's a good once a day option for them. Again, metformin first, and then the DPP-4 inhibitors afterwards if they won't take the metformin. The one drawback with DPP-4 inhibitors is the cost, but I believe we're getting close to most of them becoming generic, and I think Januvia is either it is or it's like coming up maybe within months of having a generic option. And most insurance plans do cover these pretty good. You can see here with your patient education, really, really positive, and monitor for potential thyroid medullary cancer, especially those who've had previous nodules. If there's no family history, there's no increase, there's no risk of thyroid cancer, then you can kind of you kind of move on. GLP-1 agonists. This category also has boomed recently. It started out with Byetta, which was a twice-a-day injection. It has grown to, I don't know at this point, 6, 7 different options. There's also they're up until a few months ago they were all injectable. The one caveat to this line right here is there is now an oral one, and we'll talk about that in a minute because The oral one is it's kind of difficult to take. Well, it just has to be on an empty stomach for a certain amount of time, and if it's not, then it's not absorbed, so it doesn't work. So it's almost like a stricter Synthroid, or your bisphosphonates. You know, you have to take it like it's prescribed. If not, you really need an injectable one, which passes that metabolism and absorption issues. Um, Now we've gone from twice a day Byetta to once a day Victoza to now we have options that are once a week, and they're great because it promotes. It basically it just takes the place of that GLP-1 that we were using the DPP-4 inhibitors to increase the amount of. So we can either inhibit the metabolism of it, or we can just give the patient so much GLP-1 it doesn't matter what their DPP-4 inhibitor does. And so that's what we're doing. We're kind of overloading the GLP-1 agonist so the balance tips all the way to the side of GLP-1. It also helps because patients, like I said earlier, have low GLP-1 if they've been diabetic for 5 to 10 years. So once they've gotten the use out of that DPP-4 inhibitor, they may need to go to a GLP-1 agonist, and a once a week injection is usually pretty tolerable for a lot of patients. So contraindications and precautions. You can see here pretty good. Acute pancreatitis is possible but rare. Severe GI disease you may want to avoid, and pregnancy just check with an OBGYN. I do think that they're using them. Typically used as add-on therapy. There is one that's used for weight loss. I think the weight loss is like 4 kilograms, so 8 to 10 pounds. I don't know if I would pay $600 a month for and inject myself for 8 pounds, but to each his own. But yeah, usually used for add-on therapy. Usually given, you'll see them all the time given with metformin. They're actually really good. And then there's some combinations that have insulin and the GLP-1 agonist together. Those are a little harder because the doses the ratio is set, so you kind of just have to be perfectly matched up to it. Don't use a whole lot of it, but we do use quite a bit of the GLP-1 agonist because they have great cardiovascular data also. GLP-1 agonist and the next category we're going to talk about, the SGLT2 inhibitors, fantastic cardiovascular outcomes data. Just fantastic, regardless of A1C drop, regardless of blood sugar status. They're fantastic on that, and they've been shown a lot of benefit. You can see here the patient education. One thing that I like to tell people is when they inject the insulin, they're probably going to have a small nodule under their skin. That is just the pocket of the drug sitting there. It's got to sit there and absorb over a week. So it's not usually tender. It's not usually very noticeable. They probably feel it probably when they're in the shower and they're just soaping up and they can feel that nodule. But most people are probably not going to be able to tell that it's there. So it's not a nuisance, but don't be scared that you have a nodule in your abdomen now. They come as pins, these injections, so make sure you write prescriptions for pin needles for your patients. They do have some cheap options, but insurance might cover it. And it also tells them what size to get. Again, you have once weekly options, and that really helps reduce the GI side effects. GI is really the only thing that people complained about, but the once a week injections, that side effect is gone. Most people have no idea that they're taking it. It's so tolerable. Now, SGLT2 inhibitors. This class is very exciting. These are your flozins, so canagliflozin, dapagliflozin, and empagliflozin. These reduce blood sugar by blocking reabsorption of glucose in the kidneys. So you are peeing out your excess blood sugar. The cool thing about this is there's a limit. I think it's around 180, where you have to reach a blood sugar of that level for your body for this action to take place. So it doesn't cause hypoglycemia, because if you're low, your body's not going to try to be reabsorbing glucose anyways. So it's great because they don't cause hypoglycemia. So it can also cause a reduction, very small reduction in blood pressure because it does lead to, it is kind of a diuretic, because you're going to have some water going out with that sugar, through your kidneys. Not really enough to use this as an as a hypertensive agent, but you may have to change some doses if a patient, excuse me, has controlled hypertension. So, um, a lot of uh, a lot of algorithms are moving SGLT2 inhibitors up very quickly in their algorithms. Some are even having them second line behind metformin because they have a significant reduction in cardiovascular risk and progression of renal function loss. We could talk a couple weeks about cardiovascular outcomes data. If you want the data, I have a lot of PowerPoints and easily read documentations. I'm happy to email them to you. Um, just let me know. I will bombard you with way more information than you ever want. So we could talk about these medications for a long time. I think they're fantastic. Um, when the second bullet can cause genital yeast infections and really any type of urinary tract infection. Yeast and bacteria makes sense because we are putting sugar in our urine, and bacteria and yeast like to eat sugar, so there may be an opportunistic infection. I talked to one of the clinics who was a part of the trial for these medications, and they said they themselves didn't see an increased risk of UTIs or yeast infections, but they really stress with their patients: drink lots of water, urinate often, and very good hygiene. So it may happen. We use some SGLT2 inhibitors on some patients at our hospital. Some I'm very surprised have not had an increased risk of UTI. Some have. It's probably kind of they may have an abnormal urinary tract or something like that may contribute to it. But it's something you're going to want to watch for. But you can, mention those things from earlier, and they can probably prevent that type of infection. So here are the drugs that we've gone over, and their primary glycemic effects. So which ones to target fasting, which ones to target postprandial, and which ones have a mixed glycemic effect or will work for both. Which ones have cardiovascular benefits? You can see here you've got all of your and I'm sure this is outdated, even though this is a very recent table, because these things there's so many trials going on with these diabetic agents. Because lucky for us, each one wants to be the best at cardiovascular benefits. So we're seeing a lot of information. But all your SGLT2 inhibitors, several of your GLP-1 agonists, and not so much with your DPP-4 inhibitors, but they are at least not they're not worse. They're kind of cardiovascular neutral, which is still good for us. A few slides from the AAC ACE Comprehensive Type 2 Diabetes Management Algorithm. I'm a big fan of this one. This is 2018. The ADA and ACE are working to increase their number of publications a year, and you can actually to try to keep up on top of information as opposed to having an algorithm or treatment guidelines every 10 years like some diseases have. Trying to stay up on their treatment options. So definitely I think each one has an app you can get for your phone to stay up to date. I highly recommend it because they're easily read. They put out really good short synopsis of recommendations. So table of contents, what's recommended for patients. You'll see at the top, lifestyle therapy. Well, that's always up at the top for treatment of patients. Things to teach when you have a patient who's diabetic: avoiding hypoglycemia, avoiding weight gain, what an A1C of fasting and a postprandial blood sugar are. There's a lot of teaching that can go into treating a diabetic patient, and if it's hard to teach them everything in the office, send them to the pharmacy. They'd love to talk about these things and kind of what those numbers mean and what they might see in the next couple weeks or months. Lifestyle therapy, what you can look for and how to offer it to a patient. We won't go through all these because they're all great, but they're all but there's a lot of them. So looking at other complications, if they have cardiometabolic disease or biomechanical complications, lifestyle therapy. So which ones to offer when? So if you're also treating for ASCVD risk, so cardiovascular risk, you're going to want to see if we need to treat for dyslipidemia and hypertension. If they have normal glycemia, going to diabetes, they're definitely working in comorbidities into all their guidelines, focusing on other risk factors like dyslipidemia, hypertension, obesity, which these patients are seeing because most of them have metabolic syndrome, and all of them contribute to worsening cardiovascular events. So if they have dyslipidemia, you go through and you're going to get a lipid panel, statin therapy. Most patients who have diabetes are going to be on a statin no matter what their cholesterol is, because we've seen benefits in that. Most of them going to be should be on an ACE or an ARB to prevent kidney dysfunction, unless it's contraindicated, regardless of their blood pressure. Those are very, very strong recommendations. Then you've got, if they have certain A1Cs, we're getting into glycemic control. So you can see metformin, GLP-1 agonists, SGLT2s, and DPP-4s have now jumped above our older medications. Again, insulin is not on these, because usually you give insulin when you've kind of tapped out your old therapies, or their A1C is over 9 already, because it's gonna be hard to combine a lot of oral medications to get them below 9. Now, they start out at 14, you get them below 9, maybe it's time to start coming off that insulin, and we can see if we can replace it with some more tolerable medications, oral medications, less costly medications. That's always a good option to reassess once their A1C has come down, because if they've lost a bunch of weight. I mean, have that kind of physiologic change, they're very motivated, then they're not going to need all that insulin anymore. They may just need metformin or an SGLT2 inhibitor. Here's how to start insulin or intensifying it. Here's your profiles of what you're going to see with your drugs at the top and side effects on the bottom. These are great guidelines to get used to. So with that, we are 74 slides into 140, so I'm going to stop here. This will be part 1 of the of module 10, and I'll pick up part 2 in the next video.